everybody online. Gosh, I'm very glad to be emceeing more or less. So this is our first Healthy Public Health Seminar Series speaker today. And as you may know, the Healthy Public Health Seminar Series brings together leading thinkers in public health to talk about their work. So we're really pleased today to have Dr. Daniel Zhao, who comes to us from Oklahoma. And he is the Presidential Professor of Biostatistics in the Department of Biostatistics and Epidemiology at the University of Oklahoma Health Sciences Center. And in his spare time, he is the Associate Dean for Research in the Hudson College of Public Health. And in the other extra time, he has the Associate Director of Biostats, Shared Resources at the Stevenson Cancer Center. He isn't busy at all. Invite him to come and visit with us on this very cold day. So, but Dr. Zhao has his PhD in stats from Iowa State University, and his research is really focused on design and analysis of clinical trials and non-parametrics, multiple testing, and adaptive design. So I am not a biostatistician, but that's very impressive. He's published over 100 papers. He's been on over 60 funded grants, so he's very busy, very talented in biostatistics, and he's done a whole lot of work in service, etc. So he's here to talk with us today, present his work, and talk to us about public health, and kick off our public health series. So I'm going to turn it over to you.
Thank you so much. And it's very, very great to see everybody here today. I didn't expect to be in a small and cozy classroom like this. When Dean Delea visited our school, we put him in a big auditorium. So the title of my talk is Statistical Analysis of Family Studies with Known Kinship Matrices, with applications to strong heart family study. I know biostatisticians tend to give boring talks. I hope you guys can stay with me for the next 40 minutes. I will give you a brief introduction to the strong heart study and strong heart family study, which leads to the motivation of our research. Our projects can be divided into 3 aims, and I will go through each aim one by one. For each aim, I will propose some statistical models, we'll talk about simulation studies, and then draw conclusions and results from those studies. All right, so I grabbed all this information from Strong Heart Study website. If you want to know more, you can visit their website. This is the largest study of cardiovascular disease and its risk factors in Native Americans. It was conducted in 13 tribes and 4,549 Native Americans across 4 states, including our own Oklahoma, Arizona, South and North Dakota. Since 1989, 6 study phases have been completed. So this is a very long longitudinal cohort, and the 7th phase is still ongoing. Since phase 3, a family study was conducted, and that family study will be the focus of our research. And there were over 600 publications and over 90,000 citations based on the study. As you can see, this really makes a lot of contribution to the health of Native Americans and the overall general scientific community. All right. So I want to give a brief overview of Strong Heart Family Study, which is an add-on study to the original Strong Heart study. As you know, family studies are studies of whether a disease runs in a family. And started in 1998, Strong Heart Family Study enrolled over 3,000 individuals from 94 families. So the number of families is not huge. The family sizes range from 1 as a single person in a family, and a family of 113. And then that's a large family. It runs through several generations, and the median size is 31. I want to emphasize the size because it poses challenges when it comes to statistical modeling. Okay? And the goal, of course, is to investigate the heterogeneity of CEV. One unique feature of this study is that some genetic information were collected. In particular, kinship coefficients were directly obtained by genetic tests and interview. They spend a lot of time and effort to collect that information. And the tribes, I don't know if you have to deal with tribes, they consider this genetic information very private. It's very hard to get. You have to jump through many hurdles to get this piece of information for our analysis. And I will go back to this just in a few slides. So what is a kinship coefficient? Kinship coefficient is a probability that alleles randomly selected from two individuals are identical by descent. So for example, a value of 0 indicates two persons are not related genetically. Okay? 0.5 means a value of 0.5 for identical twins, and 0.25 for two siblings. If you multiply this number by 2, so that 0.5 becomes 1, then this becomes a correlation. You know, statisticians, we can utilize this correlation to do analysis. Okay? So that's kinship coefficients. If you stack all these coefficients together nicely into a matrix, it's called a square matrix, then it's called kinship matrix. You can imagine if we have about 4,000 individuals in this study, then this will be a 4,000 by 4,000 matrix, which contains about 16 million entries. But some of them are kind of this redundant, but still we're dealing with a high dimension problem. All right, so this leads to the motivation of our research. Why do we do this? I also mentioned Dr. Julie Stoner. She is our former chair and also the PI of Strong Heart Family Study. About 7 years ago, right around when Dean Galea was visiting OU, we had a conversation. So I was teaching longitudinal data analysis at the time, and she was asking me, okay, I have issues with this study because people are using generalized estimated equation model or GE model to analyze Strong Heart Family Study. They are using this model. There's nothing wrong with this model. This model can handle correlated data. Okay? And that's the case for Strong Heart Family Study. And people love to use it. All the people are using it. And so what's the question? So she was saying, well, you know, we know this method works, but only for studies with clusters that are similar. So in this case, cluster is family. So we have different families, but we know that the range of the family sizes is from 1 to 1 to 13. Clearly, they're not the same. They're fairly different. So is this model, is this G still the valid model for Strong Heart Family Study? So that was her question. Number two, she said that we collect these kinship coefficients, use a lot of money, funding, time, effort, and nobody's using it. Why? This is really precious. Why don't people use it? Is it because it's not useful? Or just people don't know how to use it? What is the reason? You know, I'm like you guys, always busy. I don't know the answer to these questions. I said, well, these are nice questions. Let's think about it. So we played on the fact order for about 2 years. Then unfortunately, Dr. Stoner passed away due to lung cancer at a very young age. She wasn't even 50 years old at the time, which was a very sad moment for all of us. She's very important to me as a mentor and leader. So at the time we were all sad, but she had 2 or 3 PhD students in biostatistics. They're doing research with her, but did not graduate. So what should we do about that? One of the students is Sophia. So Sophia approached me and asked me if I can be her dissertation advisor. So I asked her about her progress in terms of dissertation. Well, she has done some research with Dr. Stoner, however, because Dr. Stoner was sick, going through all the treatment, and coincidentally, Sophia also lost her dad at the same time due to lung cancer. So I was shocked, and then since they haven't made a lot of progress in their dissertation topic, then it occurred to me, Dr. Stoner has these questions for me, and I didn't have an answer. I said, well, I think this makes perfect sense. Let's work on it. Are you interested? And she was interested, and so we started working on it, and she spent 2 years to finish her dissertation topics. We have one paper published for M1, continuous outcomes. We have one paper accepted for M2, binary outcomes, and we're still working on the third one. So after we graduated, we want to end the other thing. Which I think is very good for cancer stuff. So everything works out for her. So that is the motivation of our research. Then I will go through every aim one by one. So the first aim was for continuous outcome. This paper has been published last year. I want to put a slide here just to give you an overview of what is a GE model. I'm sure some of you are familiar with this model, especially Todd should know about it. But for those of you who are not familiar with GE model, this is a popular statistical model for correlated data. Whenever you have correlated data in longitudinal, it could be just here's a cluster. In families, for our family studies, we have these families as clusters. Of course, members in the same cluster have similar genetic information, genetic traits, and therefore they should have correlated outcome. So GE is a perfect model for this situation. It has two components for making inference. As biostatistician, I have to put some formula here to show my credential. So that's the model. Y is a continuous outcome that could become factors. X contains all the covariates or predictors. For example, race, age, sex, so on and so forth. And beta is regression coefficient where you make all your inference. You can tell, you can say this is a significant predictor of the response, things like that. So that's the main model, and that's the most important model where we make inference based on. It also comes with another piece. It's called working correlation matrix. The reason it's called working is because we don't know the truth. Well, we never know the truth. So we have to put something there. That's why it's called working. We know it's wrong. It's probably wrong, but we have to put something there. Oftentimes we use very simple structures. For example, independent, which assumes all the members are independent. We know that's wrong. We know they are correlated. Or exchangeable, which assume they have the same correlations. For example, the correlation between grandparents and grandchildren is the same as the correlation between parents and children. And so again, that's a little bit better, but still maybe wrong. But the magic of GE model is that even if we're doing the wrong thing, in the end, as long as we have a large sample size, okay, a large sample size, we're democratic country, right? When you have a large sample size, not many missing values, everybody has to vote, then we can still make valid inference. Okay? So that's why GE becomes so popular. It's robust. Even if you make some mistakes, you're okay in the end. However, as Dr. Stoner mentioned, there are some potential drawbacks. Because we know this method works when the family sizes are similar, which is not the case for Stoner family study. And the other thing is it does not incorporate kinship coefficients. Remember that piece of precious information you spend time and money to get. And the tribes value it so much, and we're not using it. is this a missed opportunity? Is this the right thing to do? Okay, so that is everything about GE model. And then Sophia and I, so we went on and did some literature search. Remember, Dr. Sula has a question. Why don't people use kinship coefficients? Is it because they don't know how to do it, right? Are there models that incorporate the kinship matrix? It turns out that there is a model like that. So we look at several things, and the thing that makes most sense is this Bayesian model. Bayesian model, if you look at this equation here, it's a little bit more complicated than the one I showed you on the previous slide. It has a new piece of information that is BI. BI is a random effect. What it does, it will capture the correlations. In fact, it is quantified using something sigma g squared. That is the genetic variance times AI. AI is twice of the kinship matrix. So you can see this model does utilize that kinship matrix. Okay. In addition, it also uses this genetic variance. Now, what is genetic variance? Genetic variance gives you an estimate of the variability across all the families. Okay. This genetic variance, the sigma g squared, what we estimate from strong heart family study is about 0.3 or 0.4. 0.3, 0.4. And as we did more simulation, which I will show you in a little bit, that is small. Meaning that when we look at strong heart family study across the 13 tribes, they look dramatically similar Native Americans from family to family. Okay, and that has huge implication. I will show you just in a little bit. But the point here is that this model does incorporate the genetic information. Okay? So we thought this is a model, maybe we can assess whether this model works and compare this with GEE. Is this better than GEE? If that's the case, we should recommend people to use this, right? And one thing I want to be a little bit technical here, this is a conditional model, meaning that we're not only looking at population level, but we're getting down to the patient level. Right? So it allows you to make subject-specific conclusion. So it's not a conditional model. However, it is a little bit hard to compare conditional model, which look at individuals, with a marginal model such as GEE. GEE looks at people at population level. But the good news is that when everything is linear, then things become easier. We can derive a marginal model, and we can do a fair comparison. We can compare apples with apples for computing outcome. That makes things easier. I don't want to get into detail, but when it comes to binary outcome, which I'm going to show you just in a little bit, things become muddy. Okay. So for now, things become very simple, straightforward. That way, when we are human beings, we like to compare, right? I make more money than you. You're more beautiful than me. So it's important to compare. So we want to compare between these two models, GEE and the Bayesian model. Are they all good? If not, which one is better? So how do we compare? Biostatisticians, we do this by simulations. We try to simulate data. We try to create data. We act as if we are creators. So we generate data from a model we know. You see, we know the truth. We know what is reproduction coefficients. We know whether age is a predictor, whether gender is a predictor. We generate from real from model, we know what the true values are. And then we get a lot of data sets. We can get 1,000. And for each data set, we're going to apply both models, pretending we don't know the truth, and let the model recover it for us. And we can see which one does the better job. So that's the whole idea of simulations. And we try to be more realistic, as realistic as possible. For example, age and gender. We get that from a strong heart family study. And then the genetic variance, this whole piece, is generated from the strong heart family studies. These are real numbers from that study. And we run 1,000 simulations. For kinship matrix, of course, if we want to be real, we have to use the one from strong heart family study. In addition, we also consider some families of simpler structures. For example, singleton family with only one member, nuclear family with father, mother, and 2 children, and then 2 trios. That's 2 families with single child, so 3 members, and assume the mothers are siblings. So we try different kind of kinship matrix and see how these 2 models perform. I'm kind of skipping a lot of tables here, but here are the conclusion and the results. To our surprise, because we expect GEE doesn't work well here, right? As theory tells us. But interestingly, both models had similar biases and coverage probabilities. So bias is the difference between your estimate and the true value. Of course, you want them to be close, therefore the bias should be small. And this is what we want. And we construct 95% confidence intervals. They should cover 95% of the true value, 95% of the chances. And that's what we got. So surprisingly, both models have similar biases and coverage probabilities. And the biases were close to 0. That's what we want. They give us really good, fantastic results. And coverage probabilities were close to 95%. So that's our conclusion. For continuous outcomes, it turns out, to answer Dr. Scholar's question, the researchers are doing the right thing. It's okay to use GEE. It's okay. It's totally fine. Then you would argue, well, is that then we are kind of wasting our effort to collect all that kinship matrix. Why do we collect it in the first place anyway? But I would argue that, yes, both of them work well. However, the choice depends on your needs. If you are interested in making inference on a population level, then go ahead and use GEE. If you want to get down to the individual level and make inference on individual level, then you can use Bayesian model. Okay, and that will take into the kinship matrix into account. So either way is fine. All right. We then move on to M2. This is for binary outcome. So what is binary outcome? For example, it just take values either yes or no, black or white, 1 or 0. For example, if you look at patients, they either have coronary heart disease or not. So that's binary outcome. It's not continuous like blood pressure. Again, for binary outcome, we can apply the GE model or the Bayesian model. However, the model looks a little different here. So for continuous outcome, we have linear models, but for binary outcome, we have to use this logistic regression. We have to model the logistic function, and where P is the event rates. Okay. For the Bayesian model is a little bit more complicated with the additional random effects. Remember, it is used to capture the genetic variance and kinship matrix. Okay. So the difference is very small there, but when it comes to model comparison, it becomes a little bit more complicated. It's not like a linear model for continuous outcome. You can do apples versus apples. But here, you cannot, because when things become nonlinear, it becomes difficult. I don't want to get into technical details. So we had to try some approximate method. We derived an approximate marginal mean model. We were not 100% happy with what we did, but as we searched in the literature, people just not comparing, GE as a marginal model versus a conditional model. People just not doing it. So there's no better way to compare them. We tried something there which we were not very, which is us suboptimal. But the last bullet point, we also propose a C statistic. We thought this is a better way to compare as a measure of performance. Okay, so what is C statistic? C statistic is a concordance statistic. What it does, remember, if you get a data set, you have the observed outcome. So every patient either has a heart attack or not, didn't have heart attack. And then your model can also predict. Using your model, you can predict this patient has a heart attack or not. And then you just see how agreeable they are. If there's a perfect alignment, then your C statistic is 1 or 100%. If you have a lousy model, you just flip a coin to predict, you get 50%. So this C statistic is something ranges between 0.5 and 1. Okay, the closer to 1, the better your model is. So we thought this is a good comparison. Again, we tried some simulation studies. I don't want to get into details. Everything is very similar to the previous aim. The only thing is that the true model is from a logistic regression. All right, I want to move on to the simulation results and conclusion. Again, to our surprise, we didn't anticipate GE performs well, but it did. It did. And it's no wonder the seminal paper of GE was written by 2 researchers at Johns Hopkins. And these 2 guys just won so many awards. Has tons of citations. It's wonderful. It performs well for simple family structures and small genetic variances. Okay? And that's the case for strong heart study. We have a very small genetic variance. And so it's perfectly fine, going back to Dr. Stoner's question, it's perfectly fine to use this methodology for strong heart family study. Okay? However, in rare situations where you have really complicated kinship matrix, very large genetic variance, it can break down a little bit. Okay? So my recommendation would be, if you're not sure, then try to do some simulation studies if you want to use GE. All right? Here I want to show you some real data analysis. The outcome variable is CHD event. Again, the patient either has the event or not, so it's binary. For covariates, we consider a bunch of them. By no means we're doing a thorough analysis. We're mostly doing this for illustration. So we consider age, sex, blood pressure, and so on and so forth. We compare GE with independent correlation structure and exchangeable correlation structure and the Bayesian model. We compare the C statistic, point estimates, confidence intervals, things like that. So this is a busy table, but if you look at all these numbers across, they're all pretty similar for each of the covariates, and also similar confidence intervals. I'm expecting to read all of that, but they're very similar. And all these models identify the same set of significant predictors. And the last column is also surprising. All of them give you similar C statistics. Remember, a value of 0.79 is pretty good. 1 is perfect, 0.5 is the worst, but 0.79, they all give you the same C statistic. They are same up to the 3rd decimal places. Only at the 4th decimal place, which I didn't show here, they're a little bit different. Okay, so we're done with the aim 2, and we're moving to aim 3. Aim 3 is about survival outcomes. It's still under review, and some reviewers think we should do a little bit more simulation. But you know, the student graduated, and she needs to have access to supercomputer. We use supercomputer to do all these simulations. So it's kind of hard to convince her. She has 2 small kids to do more, but she is still engaged. All right, what is survival outcome? Survival outcome is defined as time. So time from enrollment, or maybe date of randomization if it's a randomized study, to the date of event. The event could be good, could be bad, could be heart attack, could be death. For example, if you do a lot of oncology studies, it could be date of death or date of something happens. Now, when we do studies, we cannot let study run forever. We have to stop it sometime. So at the cutoff point, not everybody will experience events, right? And so there are some censored events. So because of this censoring, survival analysis is much more complicated than other type of analysis. Of course, GE, you cannot use even your GE model for survival outcomes. As we do a data literature review, there's no well-accepted method that can fully incorporate the kinship matrix. So there's no wheels there. What should we do? We should invent a wheel, right? So our aim here is a little different. We want to develop a model. We want to create a new model. But we want this model to be not drastically different than what we are familiar with. But when it comes to survival outcome, the Cox proportional hazard model is still the gold standard. So people use it all the time. Cox proportional regression model. However, that is for independent outcomes. Short half family study, we know that members within the same family are correlated. Therefore, we cannot use it. But we want to develop a model that is similar to Cox proportional hazard, because that citation, that paper was published maybe in the 1960s, maybe has millions of citations. That is the gold standard there. In addition, we also want to incorporate the kinship matrix. Remember, we have that information. We want to use it, right? So these are the two goals, and this is the model we have. So I want to explain it a little bit. We call this Bayesian proportional hazard model, where we model the hazard function. So this H stands for hazard. What is hazard in survival analysis? That's the instantaneous event rate at every time point. So you can see this is a function of time. Okay? So for example, some cancer, maybe the mortality is higher in the beginning, but if patients live long enough, the mortality becomes smaller. So that has a different type of hazard function. So we model this hazard function, HIT here, for the ith individual at time t. We model this, we decompose this into two pieces. The first piece is a baseline hazard function. Baseline hazard function, the uniqueness of this model is that it doesn't matter if you are male or you are female, if you're old or young, if you're white or black, we always have this baseline hazard. Okay, we share the same thing. However, we are using the second piece, this piece, to capture the parametric part. That's the influence of demographic information, your comorbidities. And so this setup is nice. It allows you, it's going to capture a lot of shapes of different hazard functions. And also it allows you to calculate things like hazard ratios, okay? And survival curves, things like that. So we like this. And the only thing we introduce new is this BI. That is the random effect for the ith individual. And our model is a little different than other models, because when other people propose a model with random effects, they define it at the cluster level. So everybody in the same family share the same random effect. But we do it one level down. We're saying that every individual has his or her own random effect. Imagine if you have a study with 3,000 patients, And there are 3,000 random effects, a lot of them. And we're using this to capture that genetic information, kinship matrix. Right? So that's our model. And then, so I already mentioned there are some special features of our model. We're very flexible in terms of baseline hazard. We're able to capture a lot of real life phenomenon. And then we capture the correlation using the kinship matrix. And you can, when you exponentiate the regression coefficient, there are the conditional hazard ratios. So it has a very nice interpretation there. So I want to skip some details and then just highlight some of the unique things we did. As I mentioned, the kinship matrix is very large, maybe 16 million entries. We have to do something to alleviate the computation burden. Although we're using the supercomputer already, we still want to reduce that burden. We did a single value decomposition of the matrix. We did it once for all. It helps with the convergence of this algorithm. And also the likelihood function can be really hard to get. And we did some trick to overcome that hurdle. Finally, we're able to draw posterior samples from established software package. So the Bayesian algorithm works like this. You have some prior beliefs, right? Everybody has some prior beliefs about the parameters. And then once you observe data, that should update your belief. You gain more knowledge. And so then we draw from the posterior. We combine both information to draw conclusions. And hopefully that is not too boring. Let's turn to simulation. We simulate data from exponential distribution. This is there's some critique from reviewers from journals. They're saying this is too simple. You need to do something more complicated, and which we have to do. So it depends on the student if she has time. But we're generating from really simple models, and we keep the central rate at 25%, which means 75% has the event and 25% doesn't have the event. I want to report the results here. The relative biases are all close to zero. Remember, that's what we want, and 95% credible intervals have a coverage probability of 95%. And just to say that our method works, okay? I want to illustrate using a strong heart family study data. The outcome we consider is time to CHD, so time to the first occurrence of coronary heart disease, and we consider the same set of covariates. And here's the result. The first thing I want to point out is the genetic variance. You see the last row here is about 0.4 there, which just reinforces that there's not much variability within the strong heart family study. We don't know why, but that's the case. We have 13 tribes from 4 states, but they are genetically very similar. Interesting. And then those variables such as SBP that are not highlighted. So SBP, current smoking, and microalbuminuria are not related to time to CHD. I'm not a physician. Maybe you can help me understand why that's the case, but they're not significant predictors. Those blue ones, female sex and increasing value of HDL, these are protective effects. So they are associated with longer time to first occurrence of CHD. So they're protective effect. On the contrary, those highlighted in orange, increasing age, increasing LDL, with diabetes, increasing with hypertension treatment, and increasing values of microalbuminuria are associated with shorter time to CHD. So these are kind of risk factors. All right. This is the last slide. You guys are still awake. So going back to Dr. Stoner's original question, we are very happy we're able to answer her questions. For both aim1 and aim2, it seems like GE is okay. There's nothing wrong to use them for strong heart family studies. And what people have been doing is okay. And if you want, you can also use the Bayesian model. The choice really depends on your personal preference. For the third aim, which is new, was not Dr. Stoner's original question, but we did develop a new model for survival outcome. We believe that will work and that utilize the kinship information. That's it. With that, I'm happy to take questions.
I have a quick question.
Yes.
Can you go back to the results? So current smoking wasn't associated. That wasn't one of the factors that was significant. Is that correct? Am I reading that correct? That's interesting. So how was current smoking defined? Like, they had to be smoking within 6 months, they were just smoking right then, yes, no? I obviously,
9 months, I don't know the exact definition.
Well, it's interesting.
I would have to read their documents.
Okay.
So how they define what is current smoking.
Okay.
Yeah.
Usually smoking is a factor.
Yeah, I would expect, but if you look at the credible interval, it includes 0. So it's not a significant predictor. Yeah.
Interesting.
Yeah, we were also curious why it's not a significant. Yes.
So I'm interested in, obviously the kinship matrix is a big part of what motivated this work. And I really appreciate hearing this sort of, we owe it to the people who give us this information to use it or learn from it in some way. I really like that. But a more technical question, on the survival model, so the third aim, when you said that you use the kinship matrix, this is part of what made it 16 million strong, I assume, or large, at the individual level rather than the family level. Does that allow you in this model to, let's say you have a family with 3 generations, to have a different correlation structure between, let's say, a daughter and her mother versus a daughter and her grandmother?
Exactly.
Okay.
Exactly. That's very good. That's a very good comment. If you have a random effect on a family level, then you assume all these correlations are the same. But we know, of course, parents and children are closer in terms of genetics than children and grandparents. So that correlation shouldn't be the same.
Okay.
Yes.
And that's, so on this dilemma, so one of the things we tell our students in our methods classes is, here's a complicated method, and this is why it's complicated. But at least some of what I say is, sometimes you don't need a complicated method. Sometimes a simpler method is fine.
Correct.
You found that in your first 2 aims, essentially.
Exactly. Continue.
But for survival models, it sounds like there's real value in having that the more complicated model using a kinship.
Yes and no, because we don't have GE model to compare with. So we don't have.
So you don't know.
We don't know. We don't know. Maybe you can develop a model. And in fact, I'm not joking, but in fact, that is one of my future, research interests. That is, still people don't like. Some people don't like these random effects. They like to make population level comparison. So we really, there's a need to develop a model like that.
Yeah, except those GE, you pointed this out earlier, a huge value of mixed effects or the Bayesian models is that ability to make lower level predictions. And that's huge in policy and education. There's lots of applications.
Yeah, there's a need.
And we have a problem of over interpreting populational level models.
Exactly. That's really good comment. Very good. Thank you. Yes,
That's terrific. Thank you. So you applied all of this in this closed population because you had a purpose of sample, essentially a big one, but a purpose of sample. Talk us through a little bit how you would extend this thinking to when you're worried now about external validity, and how would you apply this, if at all, if you're dealing with all populations, and particularly, that's the conceptual question. The technical part of it becomes if you were to apply weights in any of this.
When you say weights, are these survey weights? Or?
Survey weights, yeah.
Yeah, that's really good question. Yeah, I wish we have the luxury of having a validation sample.
Mm-hmm.
But as you know, it's really hard to get this. So first of all, there are not many family studies out there that collect this piece of information. And second of all, even if there are some, it's really hard to get. People just consider this information as so much valuable. But ideally, I agree with you. So we should have some kind of validated sample to do this. We somehow overcome this by using cross-validation. So a cross-validation is not ideal, but that's a permanent way of doing it right. But ideally, yes, we should be using some external data. And as you mentioned, if it's obtained using complex survey, then we should incorporate that weights into the model.
So you haven't done this yet with this approach. That would be a next step.
Thank you.
I was going to suggest that would be
We'll do that. Yes.
This might be similar to Sandra's question, but I'm curious, every time you do a study, you look back and say, I wish I had done this, or I wish I had this in the data set. So if you got to do this study again, what would you do differently to improve it, or answer new questions, or look at new populations, or whatever would be different second run through?
For this study, I don't want to totally this idea of collecting kinship matrices. I still think there's some value. Although it depends if you're not doing survival analysis, if you are happy with GEE, then you don't have to collect this information. But if you really have money to spend or squander, I would say you could collect this information. In addition, I think you should also collect more deep genetic information. Perhaps pick some genes. Perhaps do some gene expressions. It could be DNA, RNA, or something. I think these are maybe do a gene profiling. I think those may provide more information than just kinship matrix. I think kinship matrix is good, but it's just not enough. Yeah.
Thank you so much. I think for some of us, the health behavioral element is the outcome. Diet, exercise, mental health practices. So it's not always binary. It's actually hard to make a binary outcome from certain health behaviors. It's more like 3-4 categories. So it's no longer binary or continuous. It's more, categories that we are trying to apply. So it reflects better real life, right?
Yes.
So is there any nuance or any thought about applying this to non-binary, non-continuous outcomes?
Right, that's a good question. So is called the ordinal variables. Depending on the number of categories, let's say if the categories is like 9 or 10, I'm okay to treat it as continuous. But if the number of categories is like 3 or 4 or 5, then the GE can still work. All you need to do is that instead of using the logistic regression, you can use generalized logit model or proportional proportional hazard, proportional logistic regression. There's still some ways to do that. Yes, you can do it. Yeah. Question?
Thank you for your presentation. Alvin, I'm a postdoc. So I know this started with an interest in the kinship matrix, but one of the things I didn't see here or in the paper was first the comparison between basically the treating everyone as independent versus the kinship, considering the clustering, right? So what's the benefit of considering clustering at all, right? Are you going to see the benefit because your variance is correct or the bias? So that was one of the first questions I had, is whether you looked at that or not. And the second was thinking again from the large picture of what we're getting by accounting for clustering. Another approach, because you could have identical by descent, but also identical by state. And, if it's just random and you're interested in the genetic side and you have all the genetics, you can use like a polygenic risk score instead. And that might account for some of the shared genetics, allowing you to look at those environmental exposures you might be interested in. Mm-hmm. So instead of, I know this is kind of a little bit outside the scope, so, it's fine. But, instead of considering kinship in the family study, if you just did polygenic risk scores, would you see similar sort of things? And then, the first question was like, what was the benefit of actually accounting for the kinship in the first place?
Okay, so I can answer your first question. So whenever you have correlated data, if you just totally ignore that and assume everything is independent, that is already a known fact that you're going to introduce bias. And so your conclusion will be wrong oftentimes, and we already know that as a fact. That's why I didn't even look into that. We know that as a fact. But for a second question, what is it called?
Polygenic risk score.
What is that?
So if you, since the outcome is cardiovascular events, you could, from published studies, you could get the top genetic risk variance for that outcome. And then for each individual, you can calculate their genetic risk, for example. So you're accounting for their genetic risk independently as like one variable in your model, and then you can include everything else you have.
Okay, that's an interesting idea, but you're kind of using data from out sources, right? So outside sources, and then kind of borrow that and incorporate that into the model. Is that what you're doing?
Yeah, so it's fair, because you are studying in this study Native Americans, and like most of the polygenic risk scores are going to be of European descent.
Exactly.
So it's that's a quite fair.
Yeah, there's some probably some bias. But that's an interesting idea. Thank you. Anything else? Yes.
Daniel, thank you for your presentation. That was great. Less technical question, but probably just as important, going back to how you talked about, the spirit of this is to really help the people that you're studying. So how do you wrap that up into your mentoring and teaching philosophy to make that point across to those students who are learning the technical aspects, but coming back from that to understand why they are?
Yeah, that's really interesting question. When I was a graduate student 30 years ago, my professor just threw me a problem and let me solve. We just close the door and try to derive some formula. And once we're done, and he said, it's time to find the data set to see if you can apply your model. It was frustrating, and I couldn't find the data set. Now I'm doing it the other way now. I want to have a problem. I want to solve a real problem. I want to have a true, real question from the field, and then talk to the students. Are you interested in solving the problem? So I think that's the right approach. And we are problem solvers. What we do has some public health implications. So I think that education and mentoring is important for the students, so that they're doing it not for their own interest, but to like meet other people's needs. So I always think that's important. Thank you.
I think we're about out of time,
Okay.
so. but I
That's
wanna-
good. Yeah, that's good.